Well, absolutely. So the FIRE-4 study was conducted in metastatic colorectal cancer patients having a RAS-wild type tumor defined by tissue analysis. In this trial, we randomized 672 patients into the standard of care treatment FOLFIRI cetuximab until progression or intolerable toxicity, and compared this to FOLFIRI cetuximab for 8 to 12 cycles as an induction treatment, and then with a switch maintenance to 5-FU and bevacizumab. What is the rationale behind the study? Well, we thought by switching to an anti-EGFR-free treatment after having the maximum tumor shrinkage, we may prevent upcoming RAS mutations as secondary resistance mechanism. At this ASCO, we are presenting the liquid biopsy translational program. So what have we done? We measured RAS mutations and BRAF mutations at baseline, after 8 to 12 cycles on treatment, and at the time of progression. What we found was quite unexpected for us. First of all, we had 7% of patients showing a BRAF V600E mutation, and those patients really had an outcome as seen for BRAF V600E mutated cancer. So a PFS of around about 7 months, an OS of just 12 months. What was unexpected was that we found in 13%, 70 patients, we found a RAS mutation, and those patients actually had an outcome as expected for RAS mutant patients. So it was very important for us to see by a liquid biopsy at baseline, we are able to find the optimal patient population that suit for a cetuximab or for an anti-EGFR treatment in first line. The second step, as I said, we had also a liquid biopsy at the time of progression, was that we found that there was a change in the RAS mutational status during treatment. Around about 19%, so 1 out of 5 actually was RAS-wild type in the beginning and RAS mutant after FOLFIRI cetuximab. But this did not impact overall survival, and the median time until this change happened was around about 48 weeks, so basically 1 year of anti-EGFR exposure until we saw this change. So what did we conclude out of the study? Baseline liquid biopsy is a meaningful tool to find the right patient population for an anti-EGFR treatment, and B, on-treatment measurements with liquid biopsy does not really inform treatment decisions. We have to wait until recurrence or progressive disease occurs before we should do another liquid biopsy.